in colorectal cancer, the adjuvant treatment in stage 2 is a little bit difficult because the survival benefit if you treat all patients is approximately 2%. So it's a little bit too less to give chemo and too much to completely ignore it. So the question was whether we are able to find something that is better. So we used circulating tumor DNA in an tumor-informed test. It means we first tested the tumor for the mutations, and then we looked in the patient's plasma after the resection whether we can find these mutations. So this is what we did in CIRCULATE. We screened more than 2,000 patients. We analyzed it in 1,700. As soon as we knew that the patient cannot enter the trial, we stopped the analysis. And we finally randomized 1,400. So the ctDNA positivity rate was a little bit lower than we have expected. It was approximately 3%. And then we randomized this 3%, these are 41 patients, to either chemo or no chemo. And what we have observed is that in the patient that we were randomized to chemo and were actually treated, there were much less recurrences. So only 19% instead of 62% in the other patients. This is a huge difference. It was statistically significant. The hazard ratio was 0.3. So for disease-free survival in the treated versus untreated patients that were randomized, it was similar. However, we had 5 patients who were randomized to chemo but not treated. 2, because the investigator realized at the time point when he got the information chemo that the patient is positive, and he immediately did a PET-CT and identified metastasis. So bad for the trial, for the patient perhaps a good medicine. You could also say it's not a bug but a feature. But and then we had 3 patients who declined. If we integrate this randomized, not treated patients, we still have a very strong trend with a hazard ratio of 0.5 towards a better disease-free survival in the patients who were actually randomized to chemo. But this trend was then not statistically anymore.